Warm greetings to everyone joining us today for the Evolve Monthly Psychiatry Lecture Series. I'm delighted to see such a vast audience from across the nation who have made this program a grand success till date. Very good morning to all the seniors and the juniors present here. Myself, Dr. Ashwath Babu, currently working as consultant psychiatrist, Sneka Mindcare Hospital, Tirunelveli. I will be moderating today's session along with Dr. Vasiki, consultant psychiatrist, Sneka Mindcare Hospital. First and foremost, I would like to express my sincere gratitude to our course director, Dr. C. Panneer Selvam, director and senior consultant psychiatrist at Sneka Mindcare Hospital, whose vision and leadership have made this lecture possible. Today, this session holds a special significance for all of us, especially to the team. We are fortunate to have our esteemed director, Dr. C. Panneer Selvam, gracing us with his expertise as speaker for the day. I would like to express my sincere gratitude to the esteemed chairperson, Dr. T.P. Sudhakar sir, Professor and HOD, Department of Psychiatry, Apollo Institute of Medical Sciences and Research, Chittoor, Andhra Pradesh, for their gracious presence. We are truly honored to have you with us today, sir. The topic of our webinar today is pragmatic use of LAI antipsychotics. I am confident that today's session will be immensely beneficial to all of us. On that note, I move on to introduce our chairperson, Dr. T.P. Sudhakar sir. Dr. T.P. Sudhakar sir has done his MBBS in 1979 from SV Medical College, Tirupati, and his MD in Psychiatry in 1983 from AIIMS, New Delhi. Sir is currently the Professor and HOD of Department of Psychiatry at Apollo Institute of Medical Sciences and Research, Chittoor, Andhra Pradesh. In the past, he has held positions such as Professor at SV Medical College, Tirupati from 1995 to 2013, Professor at Sri Padmavati Women's Medical College. He has been examiner for National Board and Diploma and Degree exams across South Indian universities since 1988. Sir has done more than 30 publications, given many lectures in professional bodies in international, national, zonal, and state level. He was the principal investigator in WHO Government of India funded ECA study conducted between 2004 and 2007. He has held prestigious position of President of the Indian Psychiatric Society South Zone Branch from 2017 to 18. Sir, we are very privileged to have you as the chairperson for the day. Now I humbly request you to introduce the topic, sir.
Thank you very much. Good morning, everybody. It's a very pleasant opportunity for me to be associated with this August gathering. Probably this is one exercise which helps most of the postgraduates and young budding psychiatrists across the country. And the topic chosen for today is a very, very interesting one because long-acting injectable antipsychotics had a very, very long journey right from early 1970s. When I was a student in 1979-80, we had only one long-acting injectable, that is fluphenazine. It was a very popular injection known as anatensol detonate. I think Scrib was manufacturing it, and it was very, very popular among the patients who are not able to be regular on medication, whose compliance is very, very poor. And probably it was considered, long-acting injectables was considered as a last resort for most of the. And with these few words, I request Dr. Panneer Selvam to take over after the introduction. And probably after his lecture, I will add a few things if he misses something. I hope he will not miss it. Thank you very much for the real grace you have requested. Thank you.
Thank you, sir, for setting the stage. Now, I request Dr. Vasiki to introduce the speaker for the day.
Good morning, all.
Thank you, Dr. Vasiki, ma'am.
Am I audible, sir?
Yes, ma'am, you're
Yes,
audible.
you are audible.
Thank you, sir. Good morning, all. I'm Dr. Vasiki, working as a consultant psychiatrist in Sneka Mindcare Center. It's a great pleasure to introduce today's speaker, Dr. Panneer Selvam, sir. Many of us already know about sir. He's a psychiatrist. With a brief introduction, sir did his MBBS from Government Tirunelveli Medical College and MD from Prestigious Institute NIMHANS. Sir worked as a research scientist in ECT project. Later worked as a senior resident in the same institute. Sir established Sneka Mindcare Center in 2002. Later found TKTT Association. He's a great academician and he's very much interested in research and publication. He published a book about mental health in Tamil and has many national and international publication. This article about Carrie got published recently in Frontier Psychiatry, and currently he is the president of TN IPS, and he took great initiative and effort to establish TN IPS building. With such a brief introduction, I'll invite Dr. Selvam sir for further session. Over to you, sir.
Thank you, Dr. Vasuki. Respected Chairperson, Dr. T.P. Sudhakar sir, and Senior Psychiatrist, Dr. Jayendri Madams, and today moderator, Dr. Aswad Babu, Dr. Vasuki, my dear colleagues and dear postgraduates, very good morning to all of you. First, I thank our Chairperson, Dr. T.P. Sudhakar sir, for accepted to share this today's sessions in spite of his sir's busy schedule. And I'm going to talk about around 30 minutes. And I'm going to talk about will be about the pragmatic use of long-acting injectable antipsychotics. Pragmatic use of long-acting antipsychotics. So, schizophrenia, schizoaffective disorder, and bipolar disorder is a severe and chronic illness. These disorders are the most disabling because of its early onset, chronic course, and frequent relapse. It requires a continuous and long-term treatment to reduce the symptoms, improve the quality of life, and also to prevent the relapse. The duration of treatment for schizophrenia depends on a number of factors and it should be individualized. The Indian Psychiatric Society guidelines, which was published in 2017 about schizophrenia, it says that the first episode of psychosis need to receive treatment for at least 1 to 2 years as a maintenance treatment. For a second episode, or multiple episodes need to receive the treatment for at least 5 years or longer. It's not. So some patients may require a long-term or indefinite treatment, like the patient who have a early onset psychosis, the relapse while reducing the antipsychotic dose, the patient with suicidal ideas and suicidal attempt, a strong family history of mental illness, incomplete remission, multiple episodes, comorbid substance abuse. These kind of patients, they need a long-term or indefinite period of lifelong treatment with this lifelong treatment. So there is a high rate of relapse reported in schizophrenia. Up to 50% of the patients, 50 to 70% of the patients, they relapse within 1 year. Around 90% of the patients, they relapse within 2 years. So Lieberman and Kohn et al. Reported a high rate of poor drug compliance among schizophrenic patients. Within 12 months, 42% of the patients, they stop taking medications. Within 1.5 years, that is 18 months, 74% of the patients, they stop taking medication. Because of this treatment discontinuation, it may lead to a 5-fold greater chance of relapse, and it severely affects the patient's social and occupational functioning, and also it decreases the quality of life. The psychiatrists tend to overestimate the patient adherence to oral medication, but in reality, only 50% of the patients are adherent to oral medications. As a result of non-adherence, board complaints, it may lead to symptom exacerbation, frequent emergency room visit, rehospitalizations, relapse, and treatment resistance. On the other hand, the patient continues taking medications. They are highly adherent to the medication which the psychiatrist prescribed to them, which result in 70% reduction of the risk of relapse. The non-adherence is a problem throughout the course of schizophrenia and bipolar disorder. There are several factors contribute to the non-adherence, like poor insight, the complexity of drug regimens, prescribing 6-7 drugs and 3-4 times in a day, and direct impact of the symptoms like cognitive impairment, drug adverse effect, social isolation, comorbid substance misuse, and stigma. So there are various factors that are contributing to the non-adherence of the patient having schizophrenic symptoms and also bipolar disorder. Most of the first episode psychosis patient, they respond well to the antipsychotic medication and they often return to the primordial level of functioning. They'll touch the baseline social and vocational functioning. Within 1 year, 50 to 70% of the patients will experience a relapse due to non-adherence. The recurrent relapse of psychosis can lead to decrease in treatment response, worsening of the disease process, brain damage, and also damage the individual confidence, social network, and employment opportunities. So there is an aggressive and treatment and preventing the subsequent relapse is very, very essential to save the patient from neuronal damage, cognitive impairment, and social and vocational impairment. The long-acting injectable antipsychotics play a crucial role in treatment adherence, preventing the relapse, and prevent the neuronal damage and overall patient outcome. So the LAI has been traditionally reserved for the patient with non-adherence with oral medications and also for the long-standing chronic illness. But the recent research evidence shows that introducing the long-acting injectable in the early part of the illness can lead to positive outcomes such as decreased rate of hospitalization relapse. So the postgraduates and psychiatrists know what are all the available long-acting injectable, how to use the long-acting injectable, when to initiate the long-acting injectable, and when to switch from the oral medication to long-acting injectable. So the long-acting injectable are classified into first generation long-acting antipsychotic injection and second generation long-acting antipsychotic injections. There are 8 first generation long-acting injectable are available. Flufenazine daconate, flufenazine enanthate, flufenazine daconate, haloperidol daconate, and sucralfenazine daconate. Perphenazine daconate, biodiazine palmitate, and promeridol daconate. So 8 first generation long-acting antipsychotics available. So the first 5 injections available in India. Almost all the long-acting injectable was approved by FDA except sucralfenazine. Sucralfenazine is approved by the European Union and in Asian countries. And the rest of the drugs, the sucralfenazine is not approved by FDA, but other drugs have been approved. So there are 9 second generation long-acting injectables are available at present, and it is all approved by the FDA. Risperidone microsphere, that is Risperidone Consta, that is IM injection. Risperidone subcutaneous injection, Olanzapine pamoate, and Risperidone palmitate once a month injection, Risperidone once in 3 months injection, and Risperidone once in 6 month injection. And aripiprazole monohydrate once a month injection, and aripiprazole uracil once in 2 months injections. These are all the second generation drugs are available at present. So there are 7 long-acting injectables are available in India. That is flufenazine daconate, haloperidol daconate, flufenazine daconate, sucralfenazine daconate, Risperidone IM injections, Paliperidone once a month injection, and Olanzapine pamoate. These are all the 7 long-acting injectables are available in India. So the pharmacokinetic profile of the long-acting injectable antipsychotics are quite different from the oral antipsychotics. The long-acting antipsychotics are injected intramuscularly, and the drug is slowly absorbed from the injection site into the circulation. A large percentage of the injected product initially remains in the injected area, and therefore the absorption rate of LAI antipsychotic is slower than the elimination rate. So once you give an injection, it slowly absorbed from the injected area and it reaches the bloodstream. So the absorption is slower than the elimination rate. This is called a flip-flop kinetics. Most of these long-acting injectables are based on this flip-flop kinetics mechanisms works. Once the drug is absorbed from the injection site to the bloodstream, the distribution and elimination of LAI is same as the oral dosing. The non-oral route of administration of LAI may avoid first-pass metabolism in the liver, which increase their bioavailability of the drug. When you take oral drug, it will get absorbed from the gastrointestinal tract. Then after that, then through the liver, it reaches the bloodstream. But when you give LAI, it bypasses the liver and it enters the bloodstream. The slower absorption rate of LAIs lead to reduced peak and to trough plasma concentration associated with fewer adverse effect and better tolerability. The first generation oral antipsychotic medication was introduced in 1950. The poor adherence to oral medication was noticed in several patients. This led to the development of the first long-acting injectable flufenazine enanthate in 1966, and 18 months later, flufenazine decanate was introduced. The introduction of haloperidone decanate in 1981 showed a dramatic reduction in the morbidity of the patient with schizophrenia. The concept of long-acting injectable for schizophrenia was not initially welcomed by the medical professional due to fear of increased side effect, lack of efficacy, and potential for the medical-legal problems. However, a subsequent survey and the clinical trial suggested that long-acting injectable have more benefit and widely accepted. The first generation long-acting injectable, though it was introduced in 1966, remains widely utilized in many parts of the world. Even today, they are being used by the many psychiatrists, even nowadays also. The first generation long-acting injectable, that flufenazine decanate, available as 25 mg, flufenazine decanate available as 20 and 40 mg, cyclopenazine decanate available as 50, 100 and 200 mg. These these long-acting injectables, they can be given every 15 days or once a month. Haloperidone decanate is available as 50 and 100 mg. It should be given monthly. The first generation long-acting injection is very cheap. The major limitation is it produces more extrapyramidal symptoms. When compared to the oral antipsychotic, first generation antipsychotic, many randomized control trial studies have demonstrated that first generation LAI have lower discontinuation rate, reduced number of inpatient stay, and reduced admission. And there's some negative aspect of this first generation long-acting injectable is it produces acute EPS, it produces dyskinesia and hyperlactemia. The advantage of this first generation LAIs are low risk of weight gain, and so second generation long-acting injectable. The introduction of second generation long-acting injectable lead to decline in the use of first generation long-acting injectables. The second generation LAI have a better tolerance and less severe side effect than first generation LAI. The second generation LAI has a potential to prevent or reverse the accelerated frontotemporal cortical gray matter decline and to provide a greater degree of neuroprotection than first generation LAI. The metabolic syndrome is the only hindrance to the use of second generation LAI. So Risperidone LAI is the first FDA approved second generation LAI in 2003. The Risperidone LAI is available in two forms. Risperidone microsphere, that is IM injection, that is Risperidone Consta, and Risperidone LA subcutaneous injection. So the two forms is available. The Risperidone microsphere long-acting IM injection is available in India. Is available in a dose of 12.5, 25, 37.5 and 50 mg. It should be given every 2 weeks and need to concomitant oral medications. So you have to give oral medication before and after this, starting the Risperidone long-acting injections. The Risperidone long-acting subcutaneous injections is recently introduced. It is not available in India. Available in a dose of 90 and 120 mg. It should be given every month. So this Risperidone Consta IM injection should be given every 2 weeks, and this subcutaneous injection can be given every month. And there is no need for any concomitant oral Risperidone. So how to convert this oral into IM or subcutaneous injection? If the patient is getting 2 mg of oral Risperidone, you have to give 12.5 mg of Risperidone IM injections should be given once in 15 days. And subcutaneous Risperidone 90 mg once a month. The patient is getting 4 mg of oral Risperidone, then you have to give 25 mg of Risperidone Consta every 15 days and 120 mg of Risperidone subcutaneous injection every month. If the patient getting 6 milligram, then you have to give 37.5 milligram of IM Risperidone, and subcutaneous you have to give 120 milligram. It's not recommended to hike up above 120 milligram. Similarly, the patient on 8 milligram Risperidone, you have to give 50 milligram of Risperidone IM action within 15 days. One need to continue the oral tablet for 3 weeks if you are starting the IM injection. For subcutaneous, there is no need for oral concomitant medications. The dose escalation should be done in once a month only. If you want to hike up the dose, you have to do it in an interval of 1 month only. So before injecting long-acting injectable, ensure the tolerability and efficacy by taking oral Risperidone for at least 6 to 8 weeks. So you have to start oral Risperidone for 2 months, then 6 to 8 weeks. We check for the patient's tolerability and check whether the drug is really efficacious. Then you can start. The steady state is reached after the 4 injection. After 1 month only, the steady state will reach. For LAI injectable, it is recommended to continue oral Risperidone for at least 3 weeks before gradually tapering over a period of 1 to 2 weeks. So those are stabilized on lower doses start with 25 milligram every 2 weeks. On higher doses start 50 milligram every 2 weeks. Risperidone long-acting injectable appear to be well tolerated. Only less than 10% of the patient experience EPS. The long-term studies reported fewer discontinuation rate due to adverse side effect. The prolactin level and tardive dyskinesia are said to be low when switched from oral to injectable Risperidone. So injectable Risperidone, the TD and the prolactin level elevation is lower than the oral component. So Olanzapine pamoate injections. It's available in a crystal form. It's available in as 210 milligram, 300 milligram and 405 milligram vial. Can be given in once in 2 months or once a month injection. The vial is for single use only. If you reconstitute the Olanzapine LAI, or if you mix with the diluent with the crystal powder, it should be used within 24 hours. So how to convert this oral Olanzapine to LAI Olanzapine? The patient is on 10 milligram of Olanzapine, then you have to give 210 milligram of Olanzapine every 2 weeks or 405 milligram every 4 weeks. After you should give it for 2 months. After 2 months, that is 8 weeks. After 8 weeks, you can give 300 milligram as a maintenance for every month. So you can continue 300 milligram every month after 2 months, after 8 weeks. If the patient on 15 milligram of Olanzapine, then you have to give 300 milligram of Olanzapine every 2 weeks. And maintenance dose after 8 weeks, you can give 405 milligram every month or every 4 weeks. If the patient on 20 milligram of Olanzapine, then you have to give 300 milligram every 2 weeks. And the maintenance dose after 8 weeks also you have to give 300 milligram every 2 weeks. So you should be very careful in giving this Olanzapine long-acting injection. You should give a deep intramuscular injection. You should give it in a gluteal region. Aspirate for several seconds. If any blood is aspirated, the fresh drug should be prepared. Do not massage the injection site. Intravascular injection may cause post-injection syndrome. The post-injection syndrome is otherwise called PDSS, post-injection delirium and sedation syndrome, probably caused by the partial intravascular injection. It occurs in a very small number, that is 1 in 1400 injections, and that the risk is very, very low, 0.07%. 80% of the cases, the PDSS symptoms occur within 1 hour of the injections. The symptoms include sedation, delirium, confusion, dysarthria, ataxia, agitation, and anxiety. The Olanzapine long-acting injection should be administered by the trained health professional. The patient should be observed for at least 2 to 3 hours of the post-injections. Check the patient's alertness, orientation, and absence of PDSS symptoms every 30 seconds for at least 2 hours after injections. So you should not send the patient before 2 hours from your clinic. Also to wait for 2 hours. If there is no reaction, then you can send the patient. If the patient has developed PDSS symptoms and he need an urgent medical attention. So Paliperidone long-acting injection. The Paliperidone pamoate once a month injection was approved by for the treatment of schizophrenia by FDA in 2009 and European Medical Medicine Agency in 2011. Paliperidone LAI is available as once a month injection, once in 3 months injection, and once in 6 month injection. It's very recently 2023 it was introduced in once in 6 month injection. All these paliperidone injections are water-based formulation. The paliperidone palmitate, that's once a month injection, available as 50 milligram, 100 milligram, and 150 milligram. So, how to give dosage and administration? The first dose, day 1, you give 150 milligram in the deltoid region. Day 8, you have to give 100 milligram, that too in the deltoid region. After a month, after a gap of 30 days, you have to give maintenance dose of 100 milligram. This you can give in a deltoid or gluteal regions. Some patient may benefit from lower dose within a recommended range of 50 to 100 milligram based on the individual patient tolerability and efficacy. So, first injection 150 milligram in the deltoid. Day 8, 100 milligram in deltoid. After a month, you have to give 150 milligram, 50 to 150 milligram deltoid or gluteal regions. So, how to convert the dose conversion? If the patient is on 4 milligram of paliperidone, you have to give 50 milligram of paliperidone monthly injection. If patient is on 6 milligram, then you have to give 70 milligram paliperidone pamoate. The patient is doing well, maintaining well with 9 milligram, then you have to give 100 milligram of paliperidone pamoate monthly injection. Patient on 12 milligram, then you have to give 150 milligram of paliperidone monthly injection. So some side effects like nasopharyngitis, headache, akathisia, increased weight, injection site injection, anxiety. These are some of the common side effects that occurs due to these paliperidone long-acting injections. So aripiprazole long-acting injections. In 2014, aripiprazole long-acting injection was approved by the FDA for the treatment of schizophrenia and bipolar disorder. These aripiprazole long-acting injections are available in two forms. That is, one is aripiprazole monohydrate. That is once a month injection, available as 300 and 400 milligram vial. And aripiprazole uracil, once in 2 month injection, available in 441 to 1061 milligram strength vial. Patient should be stabilized on oral aripiprazole for at least 14 days before initiating the aripiprazole long-acting injection to check for the tolerability and efficacy. The aripiprazole long-acting injection is approved for the following indication, like maintenance treatment of adult patient with schizophrenia is approved, and bipolar prophylaxis and OCD, it's all a second line drug. So there is no guidelines on switching aripiprazole long-acting to risperidone or paliperidone long-acting injection. Aripiprazole long-acting injection is not licensed in patient over 65 years. And aripiprazole long-acting injection is not recommended for the dementia-related psychosis, and many sudden death was reported with this dementia-related psychosis with aripiprazole long-acting injection. Aripiprazole also not licensed for using children below 18 years is not indicated, and it should be very used in caution with the patient have a medical problem like hepatic impairment. So some of the second generation antipsychotic adverse effects are mainly the metabolic side effect, that is weight gain, very common in Olanzapine, Risperidone and Paliperidone long-acting injection, and also hyperglycemia, dyslipidemia, and injection site reactions. So pain, redness, swelling, and induration at the injection site is also very common. Especially people receiving Paliperidone or aripiprazole injection may complaints of pain in the injection site. Then extrapyramidal symptom less common than the first generation LAI, particularly the patient with the Risperidone and Paliperidone long-acting injection, they may complain of EPS like tremor, rigidity, bradykinesia, dystonia, and akathisia. Akathisia is one of the side effects usually reported with the patient who is receiving Paliperidone as well as Risperidone injection. Some sedation like drowsiness, fatigue also usually reported with the Olanzapine and Risperidone long-acting injections. So the efficacy of first generation with the second generation LAIs. Accordingly, numerous studies, both first generation LAI and second generation LAI are equally effective. The Stone et al. Reported that for maintenance treatment of schizophrenia, long-acting injectable of paliperidone, risperidone, haloperidol, flunitrazepam are equally effective in stabilizing the symptoms and preventing the relapse of the schizophrenia patients. The first generation antipsychotic have a higher incidence of EPS than the second generation LAI. So many meta-analysis by Critini et al. In 2023 indicated no difference in rehospitalization, medication interruption, or mortality when comparing first generation LAI and second generation LAI. The choice of the long-acting injection should be based on the side effect profile, patient acceptance, as well as the price. The price of fluphenazine just less than 50 rupees, whereas this paliperidone long-acting injection and this is around more than 10,000 rupees. That is 100 milligram. Now they reduced to 2,400 rupees. There's some pharma LAI, paliperidone LAI. So what is the advantage of long-acting injectable? The confidence in medication availability, predictable, stable, and sustained plasma level, lower peak plasma level, less fluctuation, no first pass metabolism. A missed injection is immediately known, especially for the long-acting injectable, because we are going to give once a month or once in 15 days. The advantage for the patient is the freedom from taking pills daily, consistent contact with the treatment team. For getting injection, they have to come to the clinic, and no risk of overdose. These are all the advantages. The disadvantages of the long-acting injectables are low dose titration, longer time to achieve a steady state level, at least for it takes more than 4 weeks, less flexibility of dose adjustment, slower disappearance of the distressing side effect. Side effect occurs, gradually it comes down. Pain at the injection site, leakage of this leakage into the subcutaneous tissue or skin may cause irritation, and sometimes it may cause abscess. Burden of frequent travel to the outpatient clinic to get injections, especially for Olanzapine injection, it should be given only by the trained nurse. So you have to travel to the clinic. And Risperidone long acting injections may need refrigeration, should be always be kept in the fridge. And the perception of stigma. So these are all the disadvantage of the long acting injectable. So what is the barrier to long acting injectable? There are several barriers being implementing in LAI. There is no prescribed guideline for LAI. Doubt regarding the benefit other than non-adherence. The question regarding whether to prescribe this for a wider population like pediatric, old age, first episode, and bipolar disorder. And also the most effective way to convince the patient. We don't have a guideline how to convince the patient related to accept this LAI, and the high cost, all the barrier of these long-acting injectables. So according to the many experts, long-acting injectable antipsychotic recommended for schizophrenia, schizophrenic disorder, delusional disorder, and bipolar disorders are second line. Schizophrenia, schizoaffective delusional disorder is the first line, and for the patient who is not compliant, and this is for bipolar disorder is always recommended only as a second line drug. So what is the right time to consider LAI? So when will you consider this patient? We have to give LAI for this patient. For example, a patient have a relapse due to poor drug adherence. A patient have a poor frequent relapse due to poor drug adherence. Please consider LAI. Patient who need long-term treatment for an indefinite period. Patient have a multiple episode. Always consider this LAI for a patient who need long-term treatment. Patient have a cognitive deficit. Usually they miss to take miss the doses. So patient have a cognitive deficit, lack of social support. If nobody is there in the house to monitor the drug intake, please consider this long-acting LAI antipsychotics. Lack of understanding about the need for the treatment. There is illness. There is a lack of insight about the illness. Then you have to continue. You have to consider LAI, comorbid substance use disorder, unstable living environment, and the patient who decide to take LAI and exhibiting the dangerous behavior and suicidal behavior during the acute episode. These are all the patient you have to consider this LAI as LAI as predominantly. You have to consider this LAI for above these patients. So recommendations for treating schizophrenia with LAI. Several guidelines recommended LAI medication for patients with recurrent relapse related to partial or full adherence, patient with persistent symptom in spite of oral antipsychotic drug, patient who prefer LAI after an acute episode. Kane and Riberia suggested that no any patient for whom a long-term treatment is indicated should be considered a potential candidate for LAI, and that even a patient refuse the option, it would be helpful to discuss the potential advantage of the LAI. The safety and metabolic effect of paliperidone, palmitate injection with oral olanzapine, weight gain and triglyceride level increase in oral olanzapine than the Paliperidone long-acting injections. So elderly people on LAI formulation, only few studies are available regarding the use of LAI in elderly persons above the age of 65. Older patients have a high risk of adverse effects such as partial hypertension, excessive sedation, and anticholinergic effect. The starting dose of antipsychotic should be 20% of the adult dose for the elderly people. Risperidone LAI and aripiprazole LAI contraindicated in dementia-related psychosis. Older patient with psychosis or bipolar disorder can be successfully treated with LAI, but you should always use with the caution. So regarding this pediatric population, FDA approved oral drug like risperidone, aripiprazole, olanzapine, urazidone, paliperidone, quetiapine for the treatment of schizophrenia with children between the age of 13 to 17 years. Likewise, oral risperidone, aripiprazole, olanzapine, quetiapine approved for the bipolar disorders for the children. The pediatric patient have a high risk of EPS and metabolic adverse effect with oral antipsychotic when compared to the adult. So the FDA has not approved any of the LAI for the pediatric populations. All LAI injectable antipsychotic used in the pediatric population lack long-term safety data regarding their adverse effect. So LAI and the neuroleptic elegance syndrome. Antipsychotic medication can cause a potentially life-threatening adverse effect like NMS. The recommendation is to immediately stop using the offending agent. NMS raises a concern about the use of long-acting injectable antipsychotic. A recent meta-analysis of 662 published case report of NMS did not show worse outcome with second-generation LAI than with the oral antipsychotic drugs. So the risk-benefit ratio revealed that second-generation LAI had a more benefit than a side effect. So LAI long-acting bipolar disorder. The evidence regarding the use of long-acting in bipolar disorder is very, very limited. The first-generation long-acting injection are not recommended for maintenance phase treatment by bipolar disorder. Most guidelines recommend this second-generation LAI as a second-line therapy for bipolar disorder. Recently, FDA approved aripiprazole LAI and risperidone LAI for bipolar disorder. The clinical experience and evidence suggest that the use of second-generation LAI is beneficial for bipolar 1 disorder with non-adherence. The Risperidone LAI was found to be more effective in protecting against manic symptoms than depressive symptoms. Paliperidone palmitate is utilized as an add-on or monotherapy for schizoaffective disorder to prevent the patient from experiencing psychotic, depressive, and manic symptoms. A patient with bipolar 1 with manic episode, aripiprazole monohydrate significantly delayed the time to recurrence of the manic symptoms without inducing the depressive episode. So the clinical evidence shows that second generation LAI are effective and well tolerated in the maintenance phase of bipolar 1 and schizoaffective disorder. Second generation LAI showed a better efficacy in preventing the manic phase than the depressive phase. Second generation LAI may be considered for patients with bipolar 1 disorder and schizoaffective disorder with predominant manic polarity, and also patients who have a non-adherent. So non-adherent patients with predominant manic polarity and for schizoaffective disorders, you can consider the second generation LAI injections. In conclusion, long-acting injectable is a viable resource, but real-world evidence shows that it is underutilized. Long-acting injectable antipsychotic can increase adherence, decrease the rate of relapse and reduce hospitalization, ensure consistent drug delivery and dose monitoring. First episode psychosis, schizophrenia, schizoaffective disorder. Patients who are not adhering to oral formulation can be treated initially with either first generation or second generation LAI. Second generation LAI is being initiated as a secondary treatment for bipolar disorder. The barrier to long-acting injectable medication include high cost and lack of prescribing guidelines. More education needed for the clinician and the patient about the importance of long-acting injectable antipsychotic. Thank you. Thank you very much.
Thank you, sir, for the lucid presentation. With more questions, we have engaged the audience a lot than earlier. They have been.
First, I should congratulate Dr. Panneer Selvam for such a beautiful, crystal clear presentation, especially which will be very useful, not only for PGs, but also for many practicing psychiatrists. It is so simple, it's like in a capsule form. It's really good. I should congratulate him for this effort, which he said is continuing almost for the last 12 months. And I hope that he will continue to do this exercise for the benefit of most of the PGs and other practicing psychiatrists. Coming to the content, there are a few things probably I will just add. One is you have to really prepare the patient and the family for any long-acting treatment. Unless you spend a lot of time, assess things, look at the pharmacoeconomics, you probably cannot do real justice to patient. The very idea of adding a LAI is to discontinue oral medication as far as possible, if not totally. So you should explain what you are going to do and how much will be the budget for the next 2 years or 5 years, or if they require lifelong treatment, how they can afford. And you have to look at the resources from which they can get this money. Because especially the second generation antipsychotics are very, very costly. And most of the patients are relatives in their enthusiasm to avoid the medication on a daily basis. They say, yes, sir, we want to go for it. But after 3-4 injections or after 5-6 injections, they slowly stop coming to. This is the usual thing which we have found out in practice. So you have to really look for the avenues from where they can get the resources to continue with the long-acting treatment. This is a very, very important aspect. Unless you yourself assess the patient and make others, especially in the family, who are actually supporting the treatment, understand the implications. Most of the times, again, you will end up with a relapse and again starting an oral medication or switching over to conventional antipsychotics. So this is one area probably every treating doctor should understand and stress on. The second thing is that, especially in first episode psychosis, usually the dictum is that at least you continue the drugs for 1 year. If there is a relapse after 1 year, again, you are not very sure whether to continue with long-acting or not. So again, here you have to do a lot of homework. First, you have to decide for how long patient may require this long-acting. Then after that, you have to educate the family based on whatever you could understand about the patient. And the other important thing which probably you have to tell to the family is that this long-acting injectables will not really reduce the side effects of this. Most of the adverse events will remain more or less the same. And the biggest disadvantage with LAI is, apart from the pharmacoeconomic aspect, is that once the injection is given, you cannot take it out. So it will remain and they have to wait for 3 weeks or 6 weeks or sometimes 12 weeks for the drug to be washed out of the system. So they have to understand this concept very well. So it cannot be like oral medication. Today you stop and within 2 days you are totally free of the adverse events. It cannot happen with a long-acting medication. Thank you very much. If at all there are any other questions which I can answer, definitely I'll answer.
Thank you very much, sir, for the kind words, sir. Now that you asked, we'll definitely make sure that the Tirunelveli halwa reaches you as soon as possible, sir. Moving on to the questions, sir. We have few questions in the chat box. Dr. Mahalakshmi has asked if there is any formula to calculate the dose of long-acting injectables, sir. And another question from Dr. Mahalakshmi again. She has asked if there is any specific recommendation of LAI for patients with bipolar disorder, multiple episodes.
Yeah, first you have to initiate whatever the drug for Risperidone or Olanzapine or this aripiprazole. You have to start oral drug. Then check for the tolerability and also the efficacy. After that, you can convert. As I in the my presentation said that how much oral. For example, 2 milligram of oral Risperidone, you have to give 12.5 milligram of Risperidone. For example, 10 milligram of the patients getting Olanzapine oral drug, then you have to give this 210 milligram once in 15 days or 405 milligram every month. After that, you have to give 300 milligram after 8 weeks. You get some maintenance dose. Those is all the dose conversion. Is there for all the drugs, all the second LA generation LAI. They given the drug how to convert with the oral drug to the long-acting injectables. And regarding these bipolar disorders, first generation LAI is not recommended. Second generation LAI, all the our Kahneman guidelines recommend Risperidone LAI for the bipolar disorders. Many recent guidelines, recent study says that these Risperidone and even aripiprazole recently is coming up. The aripiprazole, this once in 2 months injection was recently introduced around a year back, and there's a lot of research is needed. But these are all the drug with very minimal side effect. We can very well use for the patient with the bipolar disorder. Only the second line. Along with this mood stabilizer, you can add this also. So along with this mood stabilizer, you can give this long-acting injectable. The patient totally refuse the drug. At least it will prevent the manic polarity. Many of the second generation antipsychotics, they prevent the manic episode. That not much evidence for the depressive phase. But it's sure that manic phase will.
Over to Dr. Panneer, sir. So another question is from Dr. Selvi. She has asked if any test doses are needed before using LAA injections.
Yeah, actually, before starting in the LAA, we have to initiate the oral drug first. For example,
Exactly.
if you're going to start Risperidone LAA, initially try for oral drugs, for Olanzapine and as well as for the aripiprazole. So first you try oral drugs, they check for the tolerability, any adverse effect. Then you can switch over to long-acting injectable. Even with the long-acting injectable, what the guideline recommended is that you start with a very low dose. For example, Risperidone Consa, you start with the 12.5 milligram, then gradually you can increase if you suspect. But generally, they says that many guidelines says that just to try with the oral drug, the patient doesn't develop any intolerance or any adverse effect. There's allergic reaction, it won't will develop with LA also. That's what the manufacturer and the guideline says.
Yes, sir. We'll conclude with the last question from Dr. Swati. She has asked we have recommended dosage for Risperidone and Paliperidone, which we have discussed already in the presentation. She has asked if we have any dose equivalent for oral and long-acting haloperidols.
Yeah, we do have. So we have 50 milligram and 100 milligram. This haloperidol is there available. So for 50 milligram, they say as 5 milligram of haloperidol is equal to 50 milligram of haloperidol monthly injections. 10 milligram is equal to 100 milligram of haloperidol monthly. So we have a dose calculations there.
Thank you, sir. Thank you for being patient and answering all the questions, sir. I think it will be nice if we conclude with your practical experience of using extensive long-acting injections in our center, sir. That will be very much helpful to the audience rather than this lecture entirely, sir.
Thank you, Dr. Asad. Actually, in Sneka Hospital, we have a very huge crowd. We used to see more than 100 patients per day very consistently. And most of our patients are most of our population are schizophrenic patients. And the Olanzapine long active I think the southern state Sneka Hospital uses a huge volume of Olanzapine Risperidone and also Paliperidone long acting injections. And I'm not trying this Risperidone because very costly. But this Paliperidone and Olanzapine is doing an excellent response. For example, even this patient who has a poor drug compliance, we first initially, whenever the patient admitted in our hospital, we suspect that past history of very poor drug compliance, they are not continuing the for a period, for a long period. As some patient may drop the medicine after 1 or 2 months, they take the medicine, they'll drop because they think that they're doing well, they'll come out with the relapse. Then once the patient get admitted in our hospital, along with the oral drug, we give long-acting injectable also. Then I'll check in the follow-up whether the patient is continuing the drug or not. If they are not continuing, then I will continue this Olanzapine or Paliperidone, the long-acting injection. Actually, it's doing very well. So there are many patients, acceptance is very high actually. Olanzapine, when compared to Olanzapine and Paliperidone and Risperidone, Olanzapine has a high acceptance case. We are giving at least around 7 to 8 injections per day. We are giving Olanzapine. That is a huge volume. So my practical experience is really it's good. Actually, we can worth trying this drug because we practically we found that nowadays any schizophrenic disorder or bipolar disorder, they're going to be chronic because schizophrenia they don't have a recurrence, and bipolar disorder also not single episode like single episode schizophrenia or the long gap. For example, episodic schizophrenia between 3 years or 4 years gap, it's very, very rare. But what we practically were noticing that schizophrenia have a multiple relapse, and each and relapse, for example, Dr. Padmaswara said, so whenever the patient had a recurrent relapse, the inter-episode period became shorter and shorter. So the frequency the episode became longer and longer, and the inter-episode period became shorter, and episode became longer. So better way to stop that multiple relapses to give the drug for a longer period of time. In that way, this long-acting injectable is really worth giving the drug. So thank you, Dr. Padmaswara sir, for your kind words. Thank you, sir. So we are continuing almost for this is the first anniversary. We have completed 12, and this is the last first one. So I'm happy that sir has spared his valuable time. And also I thank Dr. Aswath Babu, Dr. Vasugi, and the senior psychiatrists like Jayendri madams, and many senior psychiatrists, and I'm seeing many colleagues in the on the online, and postgraduates for your patient listening and active participation. And I thank the Psychiatrist Pharma for sponsoring this Zoom link and also promoting this. They're continuously supporting us to continue this Evolve program. So many speakers, many legends had a speaker in this thing, like legend like Dr. Padmaswara sir has chaired this session. So I thank you all, and I thank you all, and we'll have a next webinar, next ELVA webinar date and time will be informed later. We'll announce soon. And who are the participants? I've seen many participants with the correct answer. I think that Praveen, East West Pharma, Praveen and Dr. Aswath will note down the first responder and this quick responder. Correct and quick responder. It will be notified and it will be informed in the next Evolve webinar. The winner will be announced, and you will get an attractive prize. We are giving a very huge and worth prize for the winner of the past Evolve episode. So with this, thank you very much. Thank you all the audience, and thank you Sudhar sir, Aswath Babu.
Thank you very much. Thank you very much,
sir. With the East West Pharma, what are thanks, we will wind up the session. Thank you, sir.
Thank you very much for the panelist. Especially cordial, we extend our gratitude to our chairperson, Dr. T.P. Sudhakar sir, and our moderator, sir, Aswath Babu sir, and especially we are extending our cordial thanks to Dr. Panneer sir to continuously doing this program for successfully we landed 1 year. So I'm requesting all PGs to please deliver this message to your colleagues also to participate. The program will be benefited, and my sincere thanks to all to those who participated, and especially our team members to reach all medical colleges. So for today we became 120 participants across. Thank you so much and have a great day to all, sir.
Thank you. Thank you all.
Thank you, sir. Thank you all.
Thank you very much.
Thank you, sir. Thank you.
All the best for you in future.
Thank you, sir. Thank you, sir.
Thank
Thank
you.
you very
Good
much,
luck.
sir. Thank you, sir.